Need for me to introduce, mashallah.
I'll take it. No, we'll take it. It's a look. Bismillah ar-Rahman ar-Rahim. Can you guys hear me? Is it working? Good. Bismillah ar-Rahman ar-Rahim. Allahumma inni as'aluka ilman nafi'an wa rizqan tayyiban wa amalan mutakabbaran. Oh Allah, I ask for beneficial knowledge, provision that is pure and good, and deeds that are acceptable. My name is Nadeem Ahmed. I'm the psychiatrist. I work at Western Psych. I'm a double board in internal medicine and psychiatry, and I'm a full-time, what you may call it, as a hospitalist psychiatrist. Primarily do inpatient acute psychiatry at Western Psych. I do specialize in the schizophrenia, subacute, and I'm here to talk about some of the basic stuff. My colleagues here, Dr. Maher Ayyash, we'll be both taking your questions. But this is more of a format, of an interactive format. So it's more like you ask question and we answer. So it's not a lecture, no slide, no nothing. So I'm hoping that you guys are prepared to ask questions so we can address them. But before we do that, let me just go over some of the basics aspects of psychiatry, what's called modern day psychiatry. The Western psychiatry, as it's called, it's a medical specialty. It used to be really loose clump of science. But in the 18th century, late 18th century, it became more of a concept that brain is the origin of all the mental illness. Before it used to be witchcraft, divine, sort of a punishment, demonic possession. So in the late 18th century, also came about what's called a asylum, a place where people were gathered. All the mental health people were gathered against their will. It's a very confined area, which would be in the outskirts of a city. And people would be gathered there against their will, and there will be a bunch of doctors who will be working with them. And then that created a society where all the mental health was secluded from the main community, and they were regarded as someone who were inferior and defected. But that also came about with an opportunity for the doctors to look into a large number of people with mental illness. So they came up with categorizing these mental illness together, and then they came up with diagnoses, and then that also gave the arena for trials of different methods. Before it was witchcraft. I mean, even in Pakistan, I came from, they used to still practice witchcraft, where they would do all sorts of inhumane things to these mentally ill people. Well, the asylum was not an ideal situation. It came in with lots of own baggage. Was the underfunded area which had no oversight. You can imagine how much abuse would have taken place in that situation. Anyhow, it did came with some positive things. And over the years, we had psychiatry in general have categorized all the mental illness into a sort of a manual. And 1952, I think, is it 1952? I think it's when the American Psychiatric Association came up with a diagnostic manual, a manual that was kind of unanimous. It had a consistency. So if somebody would diagnose a mental illness in the US, it would be consistent with the diagnosis being made in Europe or the countries. Prior to that, it was not consistent. Somebody would be diagnosed with bipolar mood disorder. It will be schizoaffective or schizophrenia in the other areas. So diagnostic manual came about with a commonality. It almost gave a sort of general concept of what mental illness is and how it is categorized. So in DSM-1, which was back in 1952, it was 132 pages. Now the DSM-5R revised, it's about 1,000 or 1,500 pages. So it has made lots of progress. Before the diagnosis of mental illness was categorized as acute brain syndrome, chronic brain syndrome, and they had categories like neurosis and psychosis. It's much more elaborated, much more comprehensive now, much more attuned with what we see now. So DSM-5R, they have categorized the mental illness into different categories. For example, early onset mental illness, which will be called as the neurodevelopmental issues. In that category, we have intellectual disability, we have language and speech difficulties disorder, for example, stuttering, We have autism spectrum disorder, which is a very broad category. It's a developmental issue that deals with not just children. I think the DSM-5 has revised the criteria to include all the adults. Now, it used to be age 3 and below. Now, there's no age limit because we have been missing the diagnosis of autism spectrum disorder in lots of kids because of various reasons. For example, they would not come into the arena and not be diagnosed, and later on they would have problems in their adult life. But autism is something that deals with poor social skills, social interaction as limited. These people could be bright intellectually, but socially they are inept. They may not be able to interact with people, may not be able to form connections, make relationships, or succeed in other areas of life. It deals with people. We deal with people in general. And then we have ADHD, which is also an evolving diagnosis. It's more treated now in adults than it's treated in children. Learning disorder, mathematic problems, learning comprehension, these are all developmental issues. It's still categorized as mental illness. A lot of times we miss those diagnoses too. Motor disorder, like tic disorder, Tourette's disorder, is also a category which is not as common, but still a mental health illness in the developmental stage. And then comes the category of schizophrenia, which is I see a lot in the acute mental health. It's a very devastating for not just for the patient, but for the family too. It's an illness that is almost like diagnosing somebody with cancer. Malignant disorder that is a sign for the rest of their life. And it's highly dysfunctional. It can cause lots of problems socially, financially, in all aspects of their lives. And the rate of schizophrenia is about 1%, and there's no difference in male and female ratio. It's equal in both genders. Bipolar mood disorder, another fascinating disorder, occurs about 2.5%. Again, male and female is almost equal. Peak onset of age in male would be about 25 to 30 years of age. So you would not have any disorder, and all of a sudden you have these mood dysregulation in the mid-20s, maybe early 30s. Actually younger in male, but older, a little bit later in life for females. Same thing. Mood dysregulation, a lot of conduct disorder. And then we have a depressive disorder, which is very common in mental health as well as in primary care. Lots of primary care physicians deal with depression. It's about 3.8 to 4% in general population. That's the prevalence, and slightly more in female than males. Anxiety disorder that we'll be talking about in great length is about 4% in general population. There's different levels of anxiety disorder in the community. There's separation anxiety, there's selective mutism, there is specific phobias. We'll be going into more detail with Dr. Maher too. It's the most common psychiatric disorder, I have to say, phobias. It's called specific phobias, which is a kind of intense, irrational fear to certain objects, to specific situation, or to concept. And people with the phobia, they go to extra length to avoid being any contact with the situation. For example, phobias to insects, perhaps, is the most common one. Insects, spiders, snakes, dogs, those kind of things will happen very commonly. And again, like I said, it's the most common mental health disorder. Social anxiety disorder, another mental illness disorder that goes undetected, undiagnosed for many, many years. It deals with people who have intense fear of going into public. They have difficulty socializing with people. They long for it, but they just can't do it. Whenever they go into public setting, they feel almost like flustered. Panic attacks, chest beat, heartbeat. They can't socialize. And what they do is to avoid being interaction. They have their family members go for them or go with them to do any activities outside of their home. These people usually have phobias or anxieties related to strangers. So forming relationships, going into public places. Academically, it's a big hindrance for them to develop. So that will be the social anxiety. Panic disorder is another disorder that's very common. It's mostly involved with physical symptoms. There are about 45 to 50 symptoms of physical illness of panic disorder. It could be from having chest pain, chest pressure, lightheadedness, dizziness, dry mouth, tunnel vision, ringing in the ear, numbness, tingling, diarrhea, GI disturbances. This could be part of the panic disorder. And when you take the panic disorder in a social setting, for example, going out in public, being in a closed space like a plane where you cannot escape for hours, it's called agoraphobia. So you cannot escape without embarrassing somebody or without embarrassing yourself. So that could be agoraphobia. And then there's generalized anxiety disorder. Generalized anxiety disorder would be more where people feel anxious, nervous all the time. It's not a panic attack that occurs in episodes. It's more of a throughout the day, you'll be tense, headaches, muscle aches, tension, can't sleep. If you sleep, the sleep is not restful. You wake up several times a night. And then physical symptom, GI symptom would be part of it too. I mean, there's other symptoms too. Less common categories of symptom that we deal with, but not so much common in the public. For OCD disorder, there's obsessive compulsive disorder, sleep disorder is another one. Substance use disorder, I have to say it's more prevalent in our community than we think. All sorts of substances occur in this community as well, so we have to be keeping our eyes open for our young kids, not just the kids, but adults too. So substance involving cannabis most commonly, alcohol. There's other illicit drugs, off-the-street drugs, cocaine and heroin. These are most common. And the one thing that's evolving in the community is the xylazam. It's a very addicting drug that's injected and that's caused severe physical illness. So these are the general categories of mental illness that we deal with. And there are other categories, for example, personality disorders. Again, a very fascinating disorder. Dr. Ayyash and I deal with this in the acute care setting, and once you see a personality disorder, it's very difficult to forget. And sometimes it can affect you socially, professionally, when you have to deal with them day in, day out. I think these are all the things that I have to say about the introduction. Any questions at this point? Because I have certain things written for specific questions I can go with you, but if you guys have any questions, we'll be happy to take that.
Maybe we can give the questions after Dr. Maher finishes.
Okay.
Yeah,
Okay.
Then we can ask.
Okay. Okay.
First of all, thank you all for taking the time out of your busy schedule to be here and join us in this workshop. My name is Maher Ayyash, and I am Assistant Professor of Psychiatry and Medical Director at the University of Pittsburgh School of Medicine and the University of Pittsburgh Physicians. I think what is relevant to psychiatry at this workshop is to really make it as simple as possible for people to understand the complicated terminology that people use. I think we have to be a little bit more specific about things that we are going to address rather than going through again terminology that lay people or regular people don't understand and scare them of this branch of medicine that even other doctors are not interested to listen to. They usually refer to psychiatrists to deal with the situation. The other thing that we face also in psychiatry, in programs, even on TVs or stuff, a lady calls in and asks a question, what are the symptoms of depression, or what are these things, which actually I would like to go through the things that are suggested to answer provided by the team of this institution. I think they are very relevant questions to the community to be answered. So usually the answer will be vague when somebody calls in, oh, I have to see the patient, this is something. No, this is not true anymore with psychiatry. Psychiatry is becoming more specific most of the time than before. Therefore, it is more comprehensible for people to understand what's the problem And we need to also know when symptoms become a problem. So I think our role in this workshop is to clarify those two issues. Starting with the answering of the questions and identification, what brings the psychiatric symptoms to be a problem is actually one simple thing. If it impairs your functioning in social, occupational, educational, and other aspects of your life. Anyone who fails a test will not feel good. Is he depressed? Yes. Is he depressed requiring treatment? The answer most probably is no. Why? Because he will be feeling not good for a few days, then go back and study for the next test and do very well. However, if those symptoms impair his level of functioning, then it becomes a problem. So that's one criteria we need to know. The second one, we need to roll out with any psychiatric or symptoms that the patient does not have, as Dr. Ahmed mentioned, that there is a substance use involved. So you need to make sure that this person is not smoking weed, he's not using cocaine, he's not doing abusing medications, over-the-counter cough syrups, those kind of things. The third one is to roll out a medical condition that can do this. For example, somebody with thyroid problem could have depression. So if you treat the thyroid problem, most probably the depression will go away. Therefore, we need to understand that. Back to the specificity or more specific symptoms, we try to avoid being vague. For example, if somebody have heart disease and this resulted in a heart attack, how and when his family will call for help? When you see this person having chest pain, shortness of breath, sweating, nausea, maybe vomiting, a pain radiated to the shoulder, so you are mentioning things that are really specific to the heart attack. In psychiatry, this is coming almost true. So most of the time, especially in female population, they usually relate things to stress. Why you are not feeling happy all this time? Oh, because I am stressed. Why you are stressed? Because of my husband. Why you are going to divorce your husband? Because he is not helpful. Why you are this? And they relate this to a stressor. In psychiatry, there are only few disorders that are related to stressors. So, for example, depression has no stressor in the diagnostic criteria. So if you are depressed, it doesn't mean the stress caused you depressed. That is something different. There are few that stress is related to some things, such as adjustment disorder. You are somebody not adjusting to with failing a test. So you become adjustment disorder with depressed mood, or with anxiety, or with emotional dysregulation. That usually does not require medication or treatment except with some psychotherapy, and you will be fine. The other one that's well known to be related to stressor other than adjustment disorder is the post-traumatic stress disorder. Somebody in the war and he is pointing at something, his peer soldier beside him, his head is gone. He suffered from PTSD seeing this guy killed next to him. There is a stressor in the diagnosis that causes this problem. Acute stress disorder. So if you look to all what Dr. Ahmed mentioned in the psychiatric disorders, you will not see stress as part of diagnostic criteria. So I hope that clarifies a very important point for most of us, that don't relate stress always to the problem, because there are other factors, environmental, congenital factors, other factors, the way you are raised, birth trauma, anything can affect. Sometimes Even in Pittsburgh, we have high prevalence of vitamin D deficiency. Vitamin D deficiency can precipitate or make you prone to have depression than other people who are living in same temperature in Denver, Colorado. Denver, Colorado has 300 days of sun. We have 100 days of sun in the Pittsburgh area. So that affects the vitamin D level, for example. Patients who have vitamin D deficiency, they are almost, if they share the same predisposing factors, they could have other illnesses more than other people who don't have vitamin D deficiency. So what I'm trying to tell you is a couple of things. We need to be specific, more specifics for our community to understand how to identify psychiatric problems, rather than being overwhelm our community with the information that they cannot make or sort out as general population, hearing terminology they never heard of, and they come to the square one asking, what is this? As Dr. Ahmed mentioned, there are many categories in psychiatry. So we passed the issue of substance, we passed the issue related to medical condition, and we also coming to the issue of specific symptoms. There are categories for what is mentioned. For example, you need to identify first the main symptom of the disorder. Is it mood problem? So that brings you the issue related in the questions that are submitted by the community in the brochure you received to depression and bipolar disorder, and they have a fancy name called affective disorder sometimes. So those are mood disorders. When you come to the thought process problem, you come to the schizophrenia, schizoaffective disorder. So basically the main issue is what makes you establish the beginning of the diagnosis. I give you an example of real life. For somebody to say, Miss X, let's call her, she is depressed. How you establish she is depressed? Oh, she is isolating. She's not saying hi to people. That's kind of social impairment. But actually, that's not how you establish the diagnosis based on her not saying assalamu alaikum or hi to somebody. It starts by one simple thing. She has to have a depressed, sad mood for a period not less than 2 weeks, most of the day, almost every day for 2 weeks. If she doesn't have that, there is no depression. You skip to other thing for the diagnosis. So this vague intuition into diagnosis does not exist anymore. If a patient does not tell you, I feel sad and I am depressed, and this has been existing for 3 weeks, 1 month, then you transition to the other symptoms. He has to have another at least 4 to make it 5 symptoms. Those symptoms include, I'm giving you the depression as an example because this is one of the examples that the director of this institution put the effort to put in the brochure. I like it. I think it's a good introduction. What are the other symptoms? So we established this lady, Miss X, has a depressed mood, feeling sad or anhedonic. What's called, you see, when I use the word anhedonia, all your eyes open up. What this guy is talking about? No. Anhedonia is lack of pleasure. You do things, you don't enjoy it. So either this one or the depressed mood has to be there. You cannot diagnose depression, this lady because she's by herself. No. Then it comes the other symptoms. What's the other symptoms? It's a group of symptoms. One of them even affects appetite. Your appetite could be more could be less. You could be waking up at night and grabbing things from the fridge all day long. You are gaining weight or losing weight, eating or not eating. You could be sleeping more, sleeping less. Your concentration is not as used to be. Your decision making, somebody tells you, hey, let's go to the park. Oh, I don't know if I want to go. You can't even make a decision. So it's called indecisiveness. And there are other things related to this. For example, somebody start thinking, even if he is from our religion, he will start thinking, I don't want to live like this anymore. So that also very important for us to understand, and that's when it causes serious impairment and it interferes with the functioning of this person because he's thinking close to taking his life. And being a Muslim does not mean Muslims don't commit suicide, by the way. I hope nobody does it, but it can happen. There are 40,000 cases of suicide in the United States per year. If you distribute that by the population of the United States, which is 4 million, it almost, I think it gets to almost, and distributed by the days, it comes to average between 80 to 100 cases of suicide per day in the United States. So that's the ones that have been accounted for. They determine this is a case of suicide. There are cases that are not accounted for. There is no one proceeded with forensic evaluation, no one suspected this is a suicide, many things. So what I am trying to say, I gave this example of depression for the mood. Those who say, oh, this guy is bipolar, same thing, it's a mood problem. He has to have at least a manic episode. He cannot be diagnosed bipolar 1, for example, which is called, and now we come to the complex stuff, bipolar 1, bipolar 2. It has to be a mania, either even any time that leads to hospitalization. I have a patient who went to England. He never had an episode in the States. He arrived to England, spent $10,000 in a day. He ended up in an institution in London. Even if it is overnight stay, that's enough to diagnose bipolar. But what is the manic part is to have elated, pervasive mood for a period. That period could be 4 days, 5 days, usually any time if admitted, but it has other symptoms. If he meets that criteria, then I start thinking. Do you know how I am trying to make those things more close to you as somebody here, or listening to this, is that you have to establish the first criteria. And then you look to the other things. This guy sleeps 3 hours a day and he is as energetic as anybody else and even more. That's a criteria. This guy spends shopping sprees, sexually promiscuous and inappropriate. This guy has racing thoughts, flight of ideas. He starts 20 projects. I want to fix the garage, do the attic, fix my car, go to Erie for the weekend and all those, and he never usually finishes anything, even if it is goal-oriented activity. So that's what I am trying to do. But the main criteria is that. And as Dr. Ahmed mentioned, there are the thought process problems. Those are the ones, even in our, I don't say our, even if we relate this to where most of us came before we immigrated to this country, those are usually the patients who are institutionalized. The ones with what Dr. Ahmed mentioned, the ones with schizophrenia, schizoaffective disorder, those are the ones that preoccupied, but it's mainly what? It's a thought process problem. It comes with it, the package of delusions, whether it's grandiose, thinking you are God, you can fix something, all the world, whether you think you are paranoid, thinking, somebody is following you or something like that, whether it's delusions of jealousy, you always think your wife is cheating on you and she never went even out of the house and never grabbed the phone on WhatsApp. So all those things can happen. There are things also we want to make sure that they don't have hallucinations and all that stuff, and those people usually they are the ones that we grab and get them institutionalized. There are things that Dr. Ahmed also alluded for that are very important, like mood dysregulation. This guy has this irritable mood, not depressed, not happy, not sad. He's irritable at least 3 times a week. And it is happening in the house and outside the house. That's a disorder that sometimes we can, this guy, oh, he's always like that. No, he's not born like that. He has a problem now that needs to be fixed. So those people like this, those are the ones that require treatment. When it becomes to what we said at the beginning, impairment in functioning is the key issue for the psychiatric disorder. Having said that, to cover a little bit of what Dr. Ahmed also thankfully mentioned, is the personality disorder. Personality disorder, those are things very difficult to fix. Why? Because it's a pervasive pattern of you as somebody. You are somebody who are using usually immature defenses, like the child in the class. The teacher says, oh, you X made the noise. No, B made that. That's called projection. Instead of saying, oh, I'm sorry, yes, I squeezed the chair, I am the one who tried to move. No, X, he made the noise. So that's example of what's called projection, immature defense. Oh, it's not my fault. It's your fault because you did not cook today. That's why your son is screaming. Don't project. You could have helped and making some food for the family instead of watching TV or looking to your phone all day on the WhatsApp. This is how personality is. There are some personalities that are really can touch our life. For example, if you have what's called, you work with somebody who has obsessive compulsive personality disorder. It's different than the obsessive compulsive disorder. Obsessive compulsive disorder, you come to a psychiatrist, he can fix you with medication. But if you have the personality disorder, we pray and plug. We'll plug and pray with therapy, and hopefully it works because it's personality. Those people, you work with them, quote, they make you irresponsible. You are doing your best job as an imam, but I am OCD person. I say, he's a good guy, but he's not really doing this. You are a doctor doing his job, but I will say, you know what? You do this thing, but you communicate with people halfway. Why? Give me an example. Oh, you told the social worker to find a place for this guy. Yes, I did. I did tell her. Oh, you did not follow up what she said. Oh, she's supposed to do her job. So I become OCD person. I make your life miserable. I make you look irresponsible. Where those people you find them, hopefully not here, you find them hiding in big institutions. If you go to big institutions, you find this person who has a title, he has OCD. If they assign you to work under him, next day, transfer. Don't stay there, because you will never get exceeding expectation or meeting expectation with him. That's one of the things. There are other things, like dependent. In our community, sometimes we see a lot of dependence, especially in females. You have to come to your appointment with the doctor. No, I am not coming. If my husband is coming to the hospital, I will come with him. She drives. She knows how to drive. She has a son who can drive her. She knows how to take the bus or the train, but she doesn't. Those people, they are a prey for the antisocial personality disorder. Those are the guys who sit in the bar and you sit beside them and you become their prey. Why? Because you are the one who's going to fix their world. The dependent has air condition problem. Her car is not working. So you come and tell her, hey, I'm going to fix your car, make your air condition working, do all that stuff for you, and at night she's in bed with him. Next day, she loses Section 8 housing. Why? Because she brought this guy at home and she has 4 kids, and this person not allowed in Section 8 housing. She loses all the benefit.
These are the things that we encounter in the hospital setting a
Yeah.
lot. Yes.
So what I'm trying to say is those personality disorder, they are into clusters, not to make it complicated, but the first cluster is usually related to the psychotic cluster like paranoid, schizoid, or schizotypal. And those clusters, they are based on like being isolated person. This is the guy with long hair, staying in his grandmother's shack in the yard. He doesn't do anything. All girls love him, the schizoid person, because he's not trying to influence anyone. But listen to this. He is 100% emotionally detached. Even if you like him, you are not even in his radar. So I'm just trying to give you a cluster. The other clusters, they have other things, including what we mentioned. But many of them are problems for some people, like doctors. What's my problem with a personality disorder? I don't like 2 people, which I should not say I don't like. I think they are not good, and doctors should be aware. One of them is the the histrionic personality. This one comes to you and she is somebody who is usually tempting, velocious. She doesn't even like you. She just wants her Xanax and go home. And you fall for this. There are the other ones, the borderline. They don't see, this is the one that we usually talk about. This is the black and white. There is no gray. You love me. It's like usually our mothers like that. Most of our mothers, they have borderline trait.
It's a very complex disorder. It's very difficult to understand.
Yes, yeah.
Even psychiatrists sometimes struggle with this.
But I am trying to give you an idea in general about the person. It's like your mother saying at 12 o'clock, hey, I love ice cream. You tell her, hey, I want to get it I will go to Giant Eagle or Walmart and get it. Oh, no, don't get it. Actually, he's saying you get dressed and go and get it. That's what she's trying to tell you. So don't listen to what she said. You take that and exaggerate it a little bit, that's a similar situation. It's just like passive aggressive, what they used to call.
I think Freud played a big role in helping us understand what borderline personality disorder. Borderline personality disorder, it's a misnomer, but it occupies about 40% of the inpatient psychiatric treatment. So, and when you deal with borderline personality disorder, sometimes you need to counsel yourself. The mental health people need to counsel themselves. It's such a draining disorder that you have to talk to your colleague to get debriefed.
Just a little touch about the anxiety disorders. I want to let you know that 40% of the visits to the emergency room are related to anxiety disorder. People go to the emergency room, hey, I'm dying, I have a heart attack. It tends to be that muscle pain or some anxiety. Somebody goes, oh, I have vague abdominal pain, I think somebody rupturing in my stomach. You know, by statistics, it's up to 40% they are related to anxiety disorders. Phobias are things that most of the anxiety disorder require medication and they require therapy. Depression, as we mentioned, just to allude to the depression, and then we can follow with your questions if you have. Usually most psychiatric disorder, they are they have some kind of medication available at this time. The medications that are now available, they are not as used to be before, addictive or something, that taboo to take them. They are having well-known side effect profile. We are not trying to minimize the side effects, but they are much better than the older generation of medications. Some of them are very helpful. Also, in some illnesses or psychiatric problems, combining that with therapy will be very helpful for people. I think I want just to mention last thing about this free talking is related to our beliefs. Our beliefs has a major therapeutic effect in our life. We are blessed by God that we have many ways that we can provide therapy to ourselves and our people around us. ألا بذكر الله تطمئن القلوب. This is something God put in our ibadat and in our religion, in our Quran. So I encourage everybody to pray, make dua for himself. I encourage you to be diligent about reading the Quran. This is really very important. I encourage you to seek help with people who will give you help, not take advantage of you. Remember, be careful when you say things to people who are irresponsible. You need to talk to people you trust, and you need to be more objective. Don't get emotionally involved with the patient, especially if the patient, you are a male and she's a female. Don't take advantage of people. This is very important. And the opposite is true, whether you are a female and giving treatment for a male, whether financial, whether it's physical or emotional. Be careful about that. So we encourage everybody to seek their support. One last point between psychiatric problems now and before. Before psychiatric problems, we think that there were less before. Maybe that's true. Why? Because that therapy that I just mentioned was more available, more abundant. People around you, they are all religious, they are all following the same morals, plus you have good support. Your son has financial problem, you say to him, hey, this is our house. You tell him he's trying to go right and left, you tell him, hey, you are at the age I get married, let's get you married. So you provide different things in order not to make things worse. The support is different. Now, everybody minds his own business, unfortunately, and even in the nuclear families, excuse me, the support is not what used to be. My generation with my father, for example, I reflect on myself a little bit. My father, when he just wants to say something, it will be there. I did not ask him, oh, you should not think that way. You should not order an orange t-shirt. No. 10,000 miles, he ordered an orange t-shirt. He wants an orange t-shirt. I did not tell him why. I went to the store. God blessed me. The first thing on sale was the best brand in the store. In front of me, his size orange shirt. I bought it, I sent it to him 10,000 miles. Now, oh, please do this. Oh, it's a chore now. Before it wasn't a chore. It was even intuition. Your intuition into your parents were different. Now, you need to ask, please do this. There is nothing wrong with asking and saying, please do that. But your parents is like this. God and then your parents. Nobody else. Even if they are not Muslims, even if they are kuffar, you need to be with them until you die, doing وَصَاحِبْهُمَا فِي الدُّنْيَا مَعْرُوفًا. He did not say, oh, وَإِنْ جَاهَدَاكَ عَلَىٰ أَن تُشْرِكَ بِي مَا لَيْسَ لَكَ بِهِ عِلْمٍ فَلَا تُطِعْهُمَا. Don't obey them against God, but go along with them in a nice way. Even in the Quran, when they chose the word uffin, وَلَا تَقُلْ لَهُمَا uffin, this comes in a very important thing with raising our generation. If you look to the letter F in the Arabic language, it's the lightest letter in the whole 28 letters. Mm-hmm. It's just air coming out of your mouth. You don't move your tongue or anything. That's it. It's coming. You should not say that to your parents. So that's what I am trying to say.
Okay.
So I hope
before I give
if you have any questions, let me know and let Dr. Nadeem know, and we're glad to answer any questions you have. I hope what I said you find it helpful.
Yeah, thank you so much for elaborating. Before we open to the question, I just have a few concepts just to clarify with you all guys. So normal stress and mental health, that was one of the questions that Imam Yaqub had. Normal stress is a temporary stress. That's really a short duration, and everybody goes through that stress. For example, preparing for the school, moving away from school to another town. That's stress, and it can affect in different ways, but it's not persistent like Dr. Ayyash had said. But if it's persistent past a certain point, you need to get some medical help. That's the triggers of stress can trigger mental illness. Chronic stress, for example, somebody lost a job and they've been unemployed for several months, still can't find anything, they're not sleeping, they're not eating, and they're losing weight, that's mental illness. Stress, acute stress, if they're tired, if they are anxious, nervous, couple days, 2 days, 3 days, mourning, for example, loss of loved ones, couple days, 2 days, 3 days, you mourn the loss of a loved one. If it goes past 2 weeks, 3 weeks, 4 weeks, you need to get some help. There was a question about inheritance of mental illness. It's a complex phenomena. It's an interplay of genetic and environmental. For example, if you do a twin study with schizophrenic individuals, monozygotic twins separated from birth, 2 people developing schizophrenia, 1 person developing schizophrenia, 1 person doesn't. It means there's a genetic component, 50%, and there's an environmental factor. So genes does not control everything. You and I may have a predisposed gene somewhere sitting dormant, and we have fortunately not been exposed to any environmental stressor. So fortunately, thank God, we did not have this manifestation. For instance, somebody moving away to another country, or they facing financial hardship, they have this dormant gene that just become manifested. So they develop schizophrenia. There's a question about mental health effect on marriage. I found out a really interesting concept. It's called walk-away wife syndrome. Has anybody heard about this? No. Walk-away wife syndrome. All right. It's a really interesting concept, which is not unusual. Even in this community, we have this syndrome. It's emotional withdrawn, decreased communication. It's a chronic thing that comes in play over a period of time. So if you're married and you have these happy marriage for the first few years, you have children, you get involved. The children become the source of your commonality. You do things for the kids. Kids grow up. Now you don't have anything common. Wife goes its own way, you go your own way, you develop your own life, and then eventually a breakdown in communication happens. And it ends up in our community, there's not a whole lot of physical divorce. Fortunately for now, that's changing too. But, for example, we talk for bare minimum thing. Bedrooms are separated. Their routines are different. And there are no emotional contact, no emotional connection between them. You say hi and hello, and when you do have contact, it's not meaningful. There's no communication. That's a virtual divorce. That's a virtual divorce.
Sleep waivers.
What's that?
Sleep waivers.
What's that?
sleep divers. They're saying okay that sleep in different rooms is called sleep divers.
It's virtual sleep divorce, that you are living under the same household, but virtually divorced. No commonality, no communication. The only contact people have is through children. Any gathering where they come together, vacation, they come together, otherwise there's no contact. And when they do come together, it's really irritable, agitated, fighting, complaining, blame game. So that's a concept. I think it's not alien to this community, and it's evolving very fast. So people who are younger, just be careful, be mindful. So it's a concept that also relates to incompatibility. For example, you have these commonality, you share children, but at then some point in time you develop your own life, and now you become incompatible. There's no commonality. There's things that you can do for it. For example, if it's caused too much stress, always spend some time together with your spouse. Find time for having a cup of tea, having something that you can do together, even if it's as short as maybe half an hour every day, maybe few weeks, few days a week. There's a concept in psychiatry that we use pretty commonly. It's called active listening. You know, if your wife talks to you about maybe a soap opera that she likes, a drama in Pakistan, and she talks to you about the details, don't brush her off. Listen to her, pay attention to it, and make sure that you are paying attention and respecting her too. Same goes the other way too. That's one of the concepts that I found out. There's another concept that's called midlife crisis. Have you guys heard of it? Midlife crisis is not unusual. It's a psychological change, which is not a DSM-4. It is a DSM-5 criteria, but it's still a mental illness. It occurs about 10 to 20% of the male population. It can occur in female as well. It's the uncertainty, dissatisfaction, desire for major changes in life. The people go through identity crisis. People go through issues where they have not achieved anything. You're an engineer. I have not progressed in my life. Now I need to change my career. I need to go back to school. I need to do some accounting, some management, business management, or I need to go to medicine. So those things happen. And you sometimes search for purpose in life. What am I here for? It can be an emotional turmoil, but it can also be a discovery, self-discovery. It could be a self-growth. Mostly is negative. It's really a turmoil. And some of the symptoms of the midlife crisis could be restlessness, anxiety, desire for capturing your youth, the nostalgia that you have. And sometimes people go into different things, such as affair with younger people. Mindful of that. Want to experience, you get bored with life. Life's routine is just a chore, and want to change careers. There's a guy that I saw. He was a surgeon in his 40s, mid-40s or late 40s. He's married, happily married, 2 children. Now he's tired with his life. He wants to go out and be a family medicine physician, which is not as demanding, and he wants to divorce his wife. And he does. And he's not happy. He explores different areas. He has a different routine, but he's not happy. He's given up his previous life, which was a more monotonous thing, doing things on a routine thing. But now he has a different thing, aspects of life, but he's not happy too.
Do you mind if I add a few things to the marriage?
Sure, yeah.
Okay.
Please.
I would like to add a few points related to the marriage issue because our community and the mosque sometimes really gets questions about what's called marriage counseling and stuff. I want to emphasize a very good point that have been studied extensively, is that don't get involved in marriage counseling if the two partners don't want to do the counseling. Like one of them at least is not interested in reconciling and doing the marriage counseling. They want out. It is not going to work. Statistics have shown that if they did that, it's not going to happen. It's just a waste of time. The other thing that they related to the divorce of people, there are a couple of things. One of them is related to bringing things from the past, such as You remember 20 years ago we were going and I wanted to buy this ring and you did not buy it for me because you were mean, man. I don't remember, but that's happened. Bringing things from the past is one of the documented things in the literature for conflicts and leading to divorce. The other one is bringing in-laws into the discussion. Try to avoid bringing the in-laws as much as you can, your mother, your sister, your this, your that. There is no need to bring things because you are not aware of all the situation. You are only seeing one angle. The other one that really caused serious problems with marriages is related to using names. For example, instead of calling your wife a liar, which she could be, is not to say you are a liar. You say what you told me is not truthful and make me feel uncomfortable. So instead of her remembering the word, oh, you called me liar. So after 10 years you have a fight, you remember when we were at this store, you told me a liar. So that name, use a description. So your wife does not clean well in the house. She is not really a good OCD person about cleaning. She just brushes things. And you call, or you find things thrown on the floor. Instead of calling her dirty, you say, hey, throwing the clothing on the floor does not make me feel comfortable, for example. Instead of calling her a name which is dirty.
By the way, we need to appreciate our wife for all the things that they do at home. Cleaning, cooking, doing things, household chores is an immense job. And we need to really pay attention to it and then appreciate it. I think we don't do that. We take that for granted. This is our culture. This is what their role is. This is what they should do. This is in this culture, in this country, it's changing fast. So I think we have to change our mindset. And our children are already doing that too. We need to catch up with them. Let me just touch base on the concept, just briefly. No, let me this answers one of the questions. So I'll just move on. Early signs of illness in children, right? Early signs of children's illness, they have a prolonged sadness, withdrawn, they change in behavior, difficulty focusing, concentration, change in the eating habit. These are the things that we need to pay attention to it. Children show depression, they don't tell you the depression, they show you the depression with their behavior. They act out. Elderly people will present with you for depression with their physical symptoms. I'm aching, I'm a headache, I can't work. These are elderly signs of symptoms of elderly people. Adult symptom of depression would be more they complain of sadness, I can't do this, I'm feeling sad. But the children and adults are two extremes. They show the depression in their behavior. Adults will be more of a physical symptom. So just be mindful of that. Yeah, I'm open to the questions if you have any.
Let me drop the mic so that anyone can use the mic.
Yeah.
For the point what you mentioned about adults becoming kind of isolated, okay? So I see that one of my family member has become that way. He's around 20 to 30 years now. He just sits in a corner. He pretends to be working, but he's not interacting with his colleagues. He's not showing any interest in the work. So what should we do in that case?
If it is really causing a problem for him, that
he's okay. So he goes to the prayer. He goes to the masjid. He prays, okay, 5 times a day. Okay, he mingles with the people in the masjid. But at work, he's not showing any interest.
if it's causing problems, like Dr. Ayyash was saying, if it's causing problems with productivity, he's not there, he's at the brink of losing his job, that's impairment. That's a clinical impairment that he needs to get help for. If, the impairment for depression is global. So it may be that he's having problem at work, but he's somehow coping at home too. But at home, he's just hanging by the thread. So he might be getting by, But at work, if it's showing that he's not as productive, he may be at the brink of losing his job, urgent help.
So when does the personality trait becomes a disorder?
Again, a very good question. There are difference between the disorder and the traits. Most of us, we have some traits. Everybody has traits. But when it comes to a pervasive pattern that all your life is led with that trait, that's what runs you day after day. That's one criteria, depending on which personality. And the second one, it caused you impairment of functioning. If somebody who is I'll tell you something. I did psychoanalysis training with Menninger Institute, which is the biggest in the world almost, and related to what's called personality stuff. And one of the patients there, she is actually going daily for therapy to manage her work, because she has a very high position that makes a lot of money. So she doesn't want to lose that, but at the same time, she knows that her personality is going to stop that work from happening. So in order to compromise out of that income, she leaves the work every day, she goes to therapy every day. Even her therapist, which somebody I did know, he's actually has to tell her, I am off work, I'm going on vacation on these days, and this is the regulation how we are going to communicate. Because otherwise, she will lose that, what I think was a CEO job. She did this, she spent almost $135,000 a year just for therapy. But that, if not spent, she will lose the other money. So the impairment of functioning could not be minimized. The traits, yes, they are there. That's why we are different. Everybody is acting or using different defensive mechanisms. I give you an example of another healthy defense mechanism that happens in life. That we usually, I think they gave it to us when we studied psychiatry. Somebody who's very aggressive guy, like he's really very aggressive, like almost close to being antisocial. But what kind of job you think he chooses? This guy becomes either a football player in school and grow and invest in it, or he works as a butcher. So he tried to sublimate his problem into butchering, instead of like taking it on others and being aggressive towards others. So it depends what kind of, and the therapy would help you in some improvement in your defenses. I gave you earlier the example of that dependent personality. Like, she does, I'm not coming to the appointment. She's seeing a different doctor.
But is that a disorder or is it
Sublimation is an terminology.
Is a defense mechanism.
a dependent is a defense mechanism?
No, dependent is a personality disorder.
I think the concept, the traits and personality disorder, like Dr. Ayyash was saying, it's a big difference. It's a big difference. The thing is, when you are in medical profession or you do psychology and you read about the personality disorders, almost like every personality disorder, it applies to you personally. Everybody has traits. Everybody has traits of dependency. Some people have traits of OCD, and those are traits make us an individual. For example, OCD, you do things regularly, and that makes you a better person because you do things more in an organized way. But if it becomes a problem when you are excessive in those traits, and that's your main focus, personality disorder, becomes
How
an
do we know that it is because
impairment.
You will know. You will know because you will have trouble
Yes.
with your boss. You will have trouble in your relationship. You will have trouble with and personality disorder, pretty severe disorder.
Yeah.
It goes without
pervasive.
Yeah, it's affects you globally. You have interpersonal difficulties with your children, with your family, with your spouse, with your coworkers, with your patients sometimes, unfortunately, that you can see.
Many of the good physicians, they have OCD traits. You will not be, in my opinion, you will not.
All complex.
Yes, we as physicians, you cannot be a good physician without some OCD traits. You know, if you have a patient, you work, for example, in the ICU, you know that this patient, he's going down and he needs to be intubated. But your shift ended, there is another one. So you, in your thing after, even if you are not working, you will be calling, oh, did you check his pulse ox? This guy, I think, oh, it's down. I told you, go. So that's kind of what keeps you going as a physician. Oh, I forgot to write this guy antibiotic. Let me call, even I am in my car, let me call the pharmacy to put the antibiotic for him because they just called me, his strep test is positive. You see what I'm saying? That obsession traits is sometimes important, but full blown, I gave you the other example of you do something, you are supposed to do it, you did it, but your supervisor says, oh, you did not get the response. That's not my job. It's the job of the case manager of the social worker. So she marks you as somebody working for her half checkpoint, not full. Why? Because you did this, but you did not get the answer back. Those people, whatever you do, they will make you irresponsible. So it changed from somebody functioning to somebody impaired in functioning. So in order for them to get that cover, where they go, they find the biggest institution in town and go find a job. So nobody looks for them.
So this is question.
No, is the narcissist and the psychopath mental disorder, and how can we deal with them?
It's very challenging to deal with a full-blown narcissist, full-blown sociopath. Sociopath is actually a degree up higher than antisocial personality disorder. Sociopath, you will find them in the prison system. Most of the prison population, almost 80%, are sociopaths. They have committed heinous crimes. These people at a lower level cannot help themselves but violate the norms of the society. So they end up in the prison system in this country. Narcissists, they're also very dysfunctional, but they would be difficult to... No, but this misconception about narcissism is that somebody who has higher power and they feel that they always make their self-importance known to other people. But a poor person can be narcissistic too. It's a sense of entitlement that they have. In every aspect of it, they want to make known, everybody know that they're more important and they should be given the attention or the due attention that they think should be given to them. And that's what the whole interaction with people revolves around. They want the self-importance to be known to other people. And if you don't give the due importance to them, they act out in different ways. They will get personal to you. They will be personal against attacking you if you don't give the due diligence. And narcissistic, in my opinion, are the most difficult people to keep in therapy. Because they will have this narcissism against the psychiatrist, against the therapist. You're not good enough. I need somebody better. I need somebody with more credentials. I need somebody who can understand me. If you have a family member who is narcissistic, it's a challenging thing.
They lack empathy, those people. It's the narcissistic patient, usually he or she is not empathic. As Dr. Ahmed mentioned, is also they like admiration. So that's why when you do the therapy with them, they are not seeking a therapist by calling the phone, hey, find me a therapist at this clinic, I will go and see them. No. Who's that therapist should be? The best in the whole state of Pennsylvania. You can tell some narcissistic traits. I've seen it a lot because I worked in the what's called consultation liaison in the 7 hospitals of UPMC in year 2003 and 2005. You will see that very easily sometimes. You see the traits at least with a patient who is already in need of psychiatric consultation, and we have a fellow or a resident or a doctor, a consultant attending who goes and see the patient, but the first thing he says, oh, I want the director of the service to come and see me. I don't want this attending or this resident to come and see me. You know what you deal with. You know, you have to appreciate the admiration of this patient. You have to be in that category in order to get at least the history. What's the problem I want to address? Because in physical setting, your goal is not to miss a physical problem. This is very important. Even with all psyche, you remember when I started talking, I said one of the 3 things you need to do is to roll out substance, roll out medical condition, then categorize the psychiatric problem and make sure that it caused impairment of functioning. I hope you find it helpful, but that's the main characteristic. When we said depression is mood, narcissistic person lacks empathy and needs admiration. That's their title.
Excuse me. Barakallahu feek على المحاضرة القيمة, and as we social different things at work, at community, at home, different social people, how can we increase or decrease mental issue around us?
Increase or decrease?
Yeah, the mental issue. They could be in fact a person to have mental issue depressed or living down or.
You are working, you know, again, we mentioned that both me and Dr. Ahmed is that there is some model in psychiatry called biopsychosocial. That's the model. So when you come to me with depression, or somebody comes to me with depression, there is the biological part that could be inherited. He has a long family history of depression. There is maybe a thyroid problem. There is a medication problem. I can give you a very interesting example of medication you will not expect, especially in females. A medication caused her that close to be divorced. And then after that, you want to be aware of what you see around you. Because we talked about also the support system we have. If you talk about your family, you have to have support, you have to have good communication so you can understand and do the active listening Dr. Ahmed mentioned. You need to listen to those people because sometimes there is something between the lines that nobody else have talked about it or discussed it. So you need to make it clear that you as a father, as a co-worker, you care about your employees. If you have your own business, you are listening to those people. Because in between the lines, there is always a message, which sometimes we call it in psychiatry, hidden agenda. Yeah. The hidden agenda is very important. The patient is coming to you saying, as he also gave a lot of examples, like the older guy coming to you, hey, my arm is aching, my joints and my throat and my this, and you think it's all physical problem. Yes, you need to roll out, but be careful what's between the line. What's between the lines is hidden agenda, that he is a depressed person presenting to you with a physical problem.
Let me take on that case,
Yeah.
the question. If it's a modifiable stress, if you have a stress related to jobs, if it's a modifiable stress, for example, you're working night shifts, if you are in control, change your shift, change the hours if you can. If not, then you have to sort of adapt to it, and there's ways of doing it. First of all, Dr. Ayyash said that rule out any medical causes if there is any. For example, thyroid illness, untreated diabetes, untreated high blood pressure. They can all cause some emotional dysregulation. agitation, irritable mood from poorly controlled diabetes, poorly controlled blood pressure, untreated thyroid, very common cause. There could be an underlying mental illness too. You may suffer from anxiety, nervousness, depression. Treat that too. There are things that you can do, physical activity. For example, find a routine. It says that 30 minutes of exercise most days of the week would be enough to help you keep yourself sort of stable. What's that?
How many times a week?
Few times a week, not every day.
3 to
3
5
times a day, 4 times a day, depending on what you can do. Find activities that are enjoyable. You actually enjoy doing by yourself, not as a family unit, not as with your children, not with your wife, but yourself. I found a hobby, and personally I can tell you it's really a relieving, a mind-changing thing. Healthy diet is really important. You know, they say diet, you need to do all the vegetables and stop the carbs. I think in the diet is the moderation. You can still eat the fat, you can still eat the protein, you can still eat the carbohydrate, but in moderation. So healthy diet is really important. In Pittsburgh, like Dr. Maher was saying, that in Pittsburgh we are deficient in vitamin D. It's a very common finding. Each time you do a level, there's a vitamin D is below the national level average. I don't know because of the sunlight or so, but make sure that your vitamins are replaced. So make sure you have a vitamin check when you go to the PCP. Make sure you hydrate yourself too.
Is it vitamin D or is it oxytocin?
Vitamin D. There's no way of oxytocin. How do you?
Yeah, because vitamin D, even in Saudi Arabia, where the heat is like 60 degrees,
Yeah.
half of the population is vitamin D deficient.
Maybe it's a
because
diet.
of also
Maybe the diet.
I think vitamin D is overplayed, to be honest.
Huh?
You get sarcoidosis, vitamin D is involved. You talk about lupus, vitamin D is involved. Vitamin D is, I think, overplayed, to be honest.
No, but when you do the level in mental health, we have developed this routine thing.
Medical.
No, you can say, you can...
Sleep apnea, vitamin D, but they also have vitamin D.
Yes, but
can
this
find-
is a reason to correct something you found that is not going right. I listen to what you say. There are patients, yes, you cannot relate vitamin D to everything, or vitamin B12. I do actually, for every patient, I admit B12, vitamin D, and TSH, in addition to their routine things. But if you find something correctable, don't miss it. That's the message we are trying to give. Back to your, yes, go ahead.
Well, my beef is that vitamin D is in everything. It can be on every platter, vitamin D. So for example, sarcoidosis, we say vitamin D. We talk about asthma, vitamin D. We talk about COPD, vitamin D. Vitamin D cannot be in everything. I know it's an easy study to do. Take a bunch of people with sleep apnea.
You know, the recent study was very scary in schizophrenia for our information. I myself got scared about it. The recent publication about it, they did a wide study. They found that patients who share the same predisposing factor for schizophrenia, same genetics, same environment, same birth trauma, what they ended up, one of them having vitamin D, one of them having no vitamin D, they found a shocking information. Almost 400 times increase in the fold of those people who had the deficiency. But that doesn't mean. To me, it means, back to his question, it is something correctable to decrease the mental illness around you. If you are intensivist, primary care provider, you find this, correct it. It's like you have a cold house, but there are many windows open. At least you know this one you can fix it by putting a plywood on it so you don't get extremely cold. The others I am working on their insulation and stuff. But back to your question, because you asked very important question, how you can affect or increase or decrease the mental illness around you. We talked about communication. We talked about, in the communication, about active listening. And also I wanted to emphasize a very good point, is the safety and the safe environment. Safety is number one in psychiatry. Whatever you do, even the law in Pennsylvania, in order to commit a person, the commitment has to include dangerousness to self or others. That's the criteria. In Kansas and North Carolina, they have additional criteria related to substance. Pennsylvania does not have substance. So we need to have safe environment, whether at home, whether at school, whether at work environment, at your business where you work. If you have a small business and you have 3 employees, make sure safety is first. If that person, my intuition tell me he has a problem that caused him not only impairment, but I started to give or to have what safety concerns about the environment at my shop, at my restaurant, at my business, that's when you have to interfere.
Let me just add to this. Well, you have an excellent question, actually. Find something to do with sleep cycle. You need to get an adequate sleep. Create a relaxing bedtime routine. Even on weekend when you don't work, you have to find a routine, going to bed, getting up, regular times. No change in the schedule. Avoid screening time at bedtime, looking at the phone, iPhone, iPad, television, anything that disrupts your sleep. It's a blue light or it's a shimmering light that causes the stimulation of your brain, part of the brain that kind of activates you. So that affects your concentration. So if you fall asleep, you are liable to get low level of deep sleep that you need for the first few hours. So make sure you don't do the screening time before bedtime. No strenuous exercise. They say light exercise is good. Strenuous exercise just destroys your sleep. Social support, you need to keep a look at social support. In this community, like we have the mosque, we have an excellent avenues of having social support. Coming here, not just doing the prayers, socializing with people. If you have problems in the community, you have professionals here, all specialty. You have doctors, you have engineers, you can socialize, you can problem solve with them, talking to them. That's part of relieving the stress. That's a really important thing. I think that's something that's understated in this community. We have a community with almost every professional, almost every walk of life. So utilize that.
I asked this question because I have a friend of mine, after a while he get in bad mood because his boss at work, he's doesn't appreciate the work, doesn't care about the staff, yelling, screaming, so a friend of mine, after a while, he got bad mood. Is that possible? Could we move him into certain mental issue?
Yeah, that's possible. For example, if he's having stress at work, what he's doing is to bringing that stress and probably translating that or taking it out on the family. He's stressed at work. He can't yell and scream at the boss. So what he does, yell and scream at his wife, yell and scream at his children. So he has to take the stress out. What he can do, if he can modify this, for example, if he can't change a job, if he can't change the routine where he would not have to encounter the same boss, because if he change the routine that he can encounter some other boss, which will be more helpful. If he cannot make those changes, then having somebody to talk to, having some sort of means to relieve the stress after work, going for a walk, riding a bike, just 30 minutes of walk, 30 minutes of time, that he can start debrief himself. Even going out in a corner, empty room and yelling, that's helpful. Taking a punching bag and boxing and doing, these are healthy exercises. You can take the anger out. But what happens is you don't take the anger out and the anger comes out spontaneously. It's be translated to your wife, your children, maybe some other people.
I wanted to mention something that we all might encounter, which is in the last few minutes we have, related to the medications we use. You will be surprised. I'm not against being medicated for certain things, but I want to give you how to, with the vitamin D story and something. We have patients, especially people suffer from migraine headache, for example. They are disabled by that. Sometimes it's exaggerated when you go to your doctor. Like you say, oh, I have this migraine, it stops me from functioning. But unfortunately, while talking to your doctor, you did not say, or he did not ask you, how frequent you have this migraine. It could be once a month, once every blue moon. You did not say that. What's the doctor impression of your migraine? Oh, you are devastated. So instead of him treating you with what's called as needed medicine for that migraine, actually, this is a real story I'm telling you. He goes into what's called prophylactic treatment of migraine. So that lady, she ended up on a high dose of what's known as beta blocker or Inderal. This lady married, she has 2 kids, functioning person, doing very well. Suddenly, she started to have no interest in her husband. She doesn't want to divorce him. He's a good man. She doesn't know what to do with him, with herself, because she doesn't want to be with this man intimate at all. 0. So she went to a gynecologist, endocrinologist, PCP, internist, anybody you think of. Finally, her PCP said, oh, let me send her to a psychiatrist. So she landed in my clinic years ago. I did all her A to Z evaluation, to be honest with you. I did not find that this lady even depressed to get to that point that she is not interested in her marital life. But she mentioned to me that she has migraine headache. I swear to God, she was at the door about to leave. I said to her, you mentioned you were taking those medications. What dose you take of those medications and how frequent? So she mentioned 2 medications that are what they are called, like they inhibit sexual desires, and they are actually, there is, just on the side, there is a book for the FDA that is published every year about the drugs and reports the side effects. And that medicine in specific, the beta blocker, causes sexual side effects with, quote, any dose. So she is unfortunately that person, and on top of that, not only the medicine that caused her that, it's also the high dose that she received. So all what I did not know that this is the medicine. Unfortunately, also for her, she has another medicine, it's called Elavil, in addition to Inderal. So I thought, you are shooting one bird with 2 bullets. One bullet is not enough. Of course, I'm not the neurologist who prescribed this. She went to a neurologist for migraine. But I called him. I said, hey, listen, did you talk to this lady how frequent she has her migraine? His answer was, no. I told him, this lady has 1 episode every 1 month or every 2 months, and she is on 240 milligrams of Inderal once a day, long acting. And on top of that, she takes amitriptyline Elavil. And you sent her to me for this problem. Are you aware that this could cause this? So we can give her a PRN medication. And what I want from you as a colleague, how about if we give her a break from the medicine and look at it in a different way? Guess what? We gave her the PRN medication. We receive a call on the voicemail. Hey, I'm back. Everything went fine. So it could be as simple as just taking history of the person in front of you, tell me what's going on, and focus on everything is said. Don't let it just go, oh, she has migraine or something. It's like bipolar patients. You know, you find doctors who give them medication that interacts with their medication. In addition, instead of using the opposite, give them a medicine that treats other problems. So instead of a medication that has drug interactions, I have a patient that has migraine. So I tell her, hey, how about a medication that hits on the migraine prophylactically and treats your bipolar? But it might cause you some weight gain. let's exercise, let's diet, let's go to the gym more, that kind of thing. You navigate the situation in a way you care for that patient. The way you should deal with your patients is the same way you want your family member dealt with. That's the way I think every physician should look at. You don't deal with your patient like he is an object. This is a patient that you should treat as if he is a family member. What do I wish for my son, for my father, for my mother, for my wife to receive from this health provider? That's how we should practice medicine. Go ahead.
Can I? Yeah, go ahead. So there's one thing that I'm speaking as a sleep physician.
Yes.
So sleep disorder is underdiagnosed, and sleep disorder does lead to depression.
Yes.
Because for apnea to terminate, the brain has to wake up.
Yes.
So with awakening of the brain, there's a lot of crippling, adrenaline, steroid imbalances. Next day, the patient is sleep deprived and is also irritable, withdrawn, an angry person.
Yes.
So that's one common reason for somebody to be, either we diagnose them personality disorder or we diagnose them as depression, and we forget that the sleep apnea needs to be treated.
I can't agree more.
So that is something that
Dr. Khaled has mentioned actually a very valid point that's very common. Sleep problems, including sleep apnea, you can think of everything. Even blood pressure can go high and out of control. You know, as simple as that. Yes.
Sleep apnea is very common in psychiatry, and same problem there.
Yeah.
You treat the sleep apnea, a lot of times they can't tolerate the device, and they end up in our arena, and we put them on medication after medication that make the sleep worse. It makes the condition even worse. They are now 2 times heavier, and they're more depressed now, and they're tired, and they can't function. That's a very common problem in psychiatry.
First of all, thank you very much for this wonderful, I would say, lecture and workshop. And I hope that this will be the last one. We need this to be like on regular basis. I think
Dr. Imam.
will be happy to arrange.
This is his doing. This is his doing. Yeah, mashallah.
Inshallah. And I would really, I have some comment. I know that the time is already gone, but I have some comments and questions that we can address later. It's not right now. First of all, some of the, I would say, the actions which you mentioned, Dr. Nadeem, for improving your social or mental health and to help the others around you. One aspect that we are, because we are Muslims, subhanAllah, we have this hadith that if you go and make wudu and pray 2 rak'ah, if you are in anger or severe stress or something, may relieve you. So that's also another, just like a side point. We mentioned about vitamin D, but we did not relate mechanistically how it is connected to the psychiatric disorders, because we saw that the claim now that it is involved with everything. So how we are mechanistically, how it is involved in all of those diseases?
Very good question with that, but the mechanism of action of many things in medicine is unknown.
That's why I asked
Yes,
this question.
yes, but again we gave the analogy. If you know that this is deficient, yes. It's like you have a lot of problems, but I am a rich man. Yep. You are poor. What's the first thing I can help you with? Give you money, right? So you know that this vitamin D is deficient, fix it. Look to the second problem. What is it? Oh, marital problems, this. But again, I want you to understand, because I see you came a little bit late, is that what is related to the issue here is that you need to look to the symptoms, not direct relationship of the stressor. We talked about that at the beginning, because the stressor is not in every psychiatric disorder.
Yeah, I fully agree again.
Complete your question.
Yeah.
I'm not posing.
Yeah, just continue. We'll be glad to answer.
Wanting to know, for curiosity, how we are linking the vitamin
Yes.
C to those, like, physical.
The mechanism is unknown.
Yeah.
That's the answer.
The third one, like, is there any intersection between the OSD and the perfectionist or the perfection?
OSD,
OCD.
OCD. Perfectionism, OCD.
And
the perfection, like, you
perfectionist.
I'll take that. Yeah.
yeah.
OCD is a disorder. It's a very repetitious disorder
Yeah.
that you cannot be satisfied by doing one certain thing. OCD can be you need to check the door, you need to wash your hand, you need to keep things organized, or rituals, lots of rituals. And you cannot break that cycle repeatedly. You have to keep checking. You have to come back, drive back home to see if you locked the door, to see if you turned the stove on. Or you have to, sometimes people drive miles and miles to see if they didn't hit anybody. They may have heard a knock in their car. Oh my God, I knocked somebody down. And they're driving around, going to work, driving around several times to make sure they didn't hit anybody, and then arriving at work 2 hours late. So that's OCD. Perfectionism is human quality. Everybody should strive for perfection. You do it at a certain level, and then at some point you say, okay, I've done my best, I'm going to withdraw. That's normal reaction. If you do this repeatedly, you need some help.
Okay. So last question, for the safety, which we mentioned about, like Dr. Ayyash was mentioning about the safety as well, to be prioritized. So if you have a co-worker, and when you are, like, interacting or dealing, and you see some, like, there is no direct response when you are, like, interacting, but all of a sudden, either by hearing or some other colleagues are telling you that he was in so severe anger after your discussion, and even he was hitting his head in the wall. Is this person would be dangerous, although it was, like, I would say it was not a personal thing, it was like many co-workers in this situation, but all of a sudden we heard about this incident. Is this, like, person has to be paid attention to, that he has to be referred, or, like, calling the HR, or, like, what would be the...
Yeah, if his reaction is out of proportion to norms, if he's hitting his head, that's out of proportion. This is a severe mismanagement of anger. There's ways of taking out the anger. Positive ways, like you said, doing the wuzu, doing 2 rakat, sitting down, drinking water, talking to a colleague, taking a time out. These are all healthy ways. If you're not doing any of those, and if you ended up in hurting yourself, yeah, definitely you need some help.
This also falls, you have to be careful about this in a situation. If you are not the person who's seen him hitting his head, you cannot commit that person. The one who only can commit that person under what's known in the law of Pennsylvania 302 commitment is the one who observed or heard the person only. Because you will be, this is clarification, because actually I just received a call from another center about this issue. So you have to be the person who witnessed and experienced, because the question from the judge will be, what did you see of Mr. X in the past 30 days only, not 31? Because if he has a good public defender, he will get him out.
Let me take this back, sorry.
Yeah.
The 302, that Dr. Ayyash was talking about, is the involuntary commitment. So if somebody's committing act, that they're danger to themselves, everybody here has a responsibility of acting to prevent this.
That was my question regarding this.
If this is situational, if you feel that this person is taking his anger out and not a pattern of his behavior, like repeatedly, if you see somebody at the bridge, for example, and they have their leg on one and the other leg on the other, you'd be surprised how many times a bystander has saved people's life. Somebody walking down, seeing this person on the bridge, talking to this person out, calling the police, and the police comes in, they say, okay, come to the hospital, we'll take you voluntarily. No, I don't want to go, I want to jump. You take this person, they put them in the car, and they file something called involuntary commitment. It's a 302 that they can, everybody in Pennsylvania, not just police officers and doctors, everybody who's witnessed the information firsthand, not a hearsay. Firsthand, this person was trying to jump off. They can file something called a 302, involuntary commitment, psychiatric evaluation for up to 5 days, 96 hours. So they are taken by the police. They have an arrest warrant issued to them by the police. The police search them, put them in the car, bring them to the psychiatric hospitalization. We see them all the time. You see them, okay, this is a guy who has been depressed for 2-3 days or 3 weeks, and he doesn't want to live anymore. He wants to jump. That's enough ground to do the 302. So you can commit this person in a psychiatric hospital. What happens routinely, we find the extension for that. We do a 303, which is a 20-day commitment, up to 20 days. So this person is in the hospital. We treat them against their will. That's a pretty common scenario. Psychiatrists, most of the psychiatrists working in the inpatient treatment and the emergency room physician, they see it all the time.
I want just to add a few notes to what's said, is that the witnessing of that action, usually in order for successful, because your goal is actually to help that person, is the dangerousness to self. Like he said to the guys, hey, I am not happy with this, I just want to harm myself or kill myself. That by itself sometimes doesn't hold well. It's called in the law of 1976 or 79, I think. It's called, it requires furtherance of the dangerousness. And what does that mean is what Dr. Nadeem mentioned, is that this guy started hitting his head to the wall, or he was on the bridge. He said, I want to kill myself. That's not enough. But he put one leg up. That one leg up is the furtherance of the dangerousness. So when we receive things, let's be relevant to our community here and in other centers, is that you will receive a call, oh, my son is doing this, my husband is doing this. Now, in order to commit that person, you as the one responsible for the institution, you cannot do that. You have no right legally to do it. Who has the right is to be concise with the statement. You don't go in circles, don't be tangential, don't be circumstantial, be goal-oriented. Find out what's the real situation, and the one who witnessed it is the one who proceeds. That's the summary of it. Those two requirements has to be there. I hope that answers the question.
That's great, thank you.
On a lighter note, political as I am, is my president a narcissist? Does he have ADHD or is bipolar?
What's the question again?
My president, is he narcissist?
I'll
Does he have ADHD?
I'll take that. This is the classic case of narcissistic personality disorder.
Me or him?
No, I'm talking about, you're talking about, are you talking about the President of the United States? I misunderstand you.
Just kidding. I said, does it mean me or him?
Hello.
Whom you are referring to?
No, I'm talking about him, you're right.
You're talking about our President. Classic case of narcissistic personality disorder. There's no question about it. He is a self-importance. He says everything that's good. And if you don't praise him, or people don't praise him, you get kicked out. You suffer the consequences. People have lost. The problem with this person is he's got narcissistic personality disorder, and he's got the power to match this. So he becomes a Pharaoh. He can destroy people. He can do lots of damage. And
He's doing a lot of damage.
that's a bad combination. If anybody who has the power and they have narcissism, that's what we're seeing.
I think as our president, we have to pray for him to guide us through the right path.
We need to kick him out, I think.
And I think, he became the president through legitimate election. And as we mentioned in the process, everybody has a trait. And I think, the council around him, hopefully God guides them to provide him with the right decision. And I wish the best for all of us, including our president.
Any questions from the sisters? It was good. Okay, we cannot thank you enough.
Thank you all.
We invite you to come back again.
One thing I would suggest,
I had a lot of questions that I didn't have any
one thing I would suggest that we have 2 psychiatrists here. I think we need to have a mental health clinic.
Yes.
I can talk with people. I think this is very important. That the amount of people who need help in this community is surprising. So many people approach us for counseling. So I
Thank
think
you,
it's
guys.
Thank you so much. Jazakumullah.
أدن المغرب ها؟
لا لسه بدري.
بارك الله فيك.
جزاك الله خير.
Thank you.
Thank you.
ما شاء الله يعني.
بارك الله فيك.
What's that? Oh yeah.
عامل ايه يا باشا؟ جزاك الله خير.